Support Microbe TV. It's time for our annual fundraising drive. We depend on your support to produce high-quality science videos and podcasts, and now is the time to help us. If our programs have appealed to your science interests, or if they have helped you in some way, please record a brief audio or video with your phone and tell us about it. Let us know how we empower your inner scientist. We'll use it for our fundraising efforts. Send it to incubator@microbe.tv. And for more information on how you can give us your support, go to microbe.tv/contribute.
From Microbe TV, this is Infectious Disease Puscast, episode 68, recorded on Thursday, November 21st, 2024. Hello, everyone. I'm Daniel Griffin, and joining me today is Sarah Dong.
Hi, everyone. I'm Sarah. Sorry to have missed our last episode. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. Thanks for holding down the fort, Daniel.
Well, apparently I told bad dad jokes and people were not happy. And they're like, you can't leave him unsupervised, Sarah. Come back.
No, it was perfect.
Yeah, I don't know if you listened, but I told the joke about how do you hide a $100 bill from a pediatrician or an ID doc. You leave it on the table, they won't know what it is.
Excellent. I think we have a lot of good articles today. I'll have us start. Podcast is a review of the ID literature for the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we?
All right, I'm going to start us off with viral. Remember to listen to TWIV. A lot of action going on over there, particularly with some recent political stuff in the U.S. So Vincent and the crew are fired up. But let me ask, do we have any Star Trek fans? If so, let me say that I think the Borg got it wrong, Sarah. Resistance is not futile. It is inevitable. And so we have the article, Comparative Emergence of Maribavir and Ganciclovir, resistance in randomized phase 3 clinical trial for treatment of cytomegalovirus infection, published in JID. And here these investigators looked at 574 patients receiving Maribavir or Ganciclovir for first episode CMV infection after hematopoietic cell transplant. The treatment response rate was 69.6 for Maribavir and 77.4 for Ganciclovir. And development of Maribavir and Ganciclovir resistance was compared. Prior antiviral drug exposure was limited, with only 2 instances of baseline drug resistance detected. An equal number, 241, received Ganciclovir or Maribavir for at least 21 days. Among them, drug resistance mutations were detected in 10% of the Maribavir recipients after starting therapy, including 12 of 14 who experienced you ready for this, viral load rebound while on therapy. The Ganciclovir resistance developed in only 2.5%. And this was farther out. This was 66 to 110, so a median of 90 versus a median of 56. One Maribavir recipient developed a novel UL97 gene mutation. That's the P-loop substitution G34-3A. That will not be on the boards. That conferred strong Maribavir and Ganciclovir resistance in vitro. So, Maribavir resistance emerged earlier and more frequently than Ganciclovir resistance, but was usually treatable by using the alternative therapy. All right, we've also got the article, Yellow Fever Breakthrough Infections After Yellow Fever Vaccination, a systematic review and meta-analysis published in the Lancet Microbe. A lot of interesting stuff here. We've got a lot of articles, so I'm just going to cut to the chase. These findings suggested that, yes, this is a one and you are done vaccine, and that a single dose of yellow fever vaccination is sufficient to provide lifelong protective immunity against symptomatic yellow fever. All right. And the last one we have here in our viral section, the article, Serological Evidence of Natural Exposure to Rabies in Rural Populations in Gabon, was published in PLOS NTDs. This is one of those papers that's like so good. I'm like talking to people that are not even ID docs. So is rabies really so deadly? Is it really true that if you get rabies, you're going to die? Maybe people get rabies and we just don't know they have rabies, and maybe they do okay. So they carried out this crazy retrospective serological analysis on 430 sera collected between 2005, 2008 from rural Gabonese populations. They detected 11 positive samples, so 2.5% of these folks were positive. 3 of these positive people resampled in 2023. One was still found positive, suggesting that a couple things. One is that people could actually get rabies and get all better. We never know about it, and that immunity can actually persist over many years. So as they say, this study demonstrates that rabies is actively circulating in Gabon, and that some unvaccinated individuals living in rural environments can be exposed to the virus and survive. Survival despite exposure to rabies could be associated to the development of significant and specific immune response that could persist for 15 or more years. Yeah. Kind of paradigm changing, right, Sarah? Because we always teach.
Yeah. The whole time you were saying that, I was like, oh, that's like so the opposite of anything.
Right. Everyone's like, you get rabies,
Right.
100% fatal, other than that girl in Milwaukee, right? But now we're like,
Yeah.
oh.
That's really interesting. Yeah.
All right. Bacterial. Be sure to listen to This Week in Microbiology. The article, Azithromycin Exposure in a 10-Day Window of Myocardial Infarction and Short and Long-Term Outcomes, recently published in JACC Advances. So retrospective cohort study using the Meritive Market Scan database, looking at adults in patients admitted with myocardial infarction from January 1, 2010 to December 31, 2017. Basically looking at azithromycin exposure 7 days pre-MI to 3 days post-MI compared to folks that were not exposed. Really impressive curve, right? So they've got this cohort of over 18,000 eligible patients. Over 3,000 end up getting azithromycin, but then we've got 8,180 patients. Probability of subsequent myocardial infarction up to 5 years was 15% in the azithromycin group, 9.7% in the control group, like a 50% reduction. Probability of incident heart failure was 39.8 in the azithro versus 35.5 in control. So that's about a 10% increased risk. Odds of all 4 30-day outcomes that they were looking at were significantly higher in the azithromycin group. So maybe not so innocuous handing out all those Z-Packs, right?
I feel like I need to look at this one a little bit closer. Everyone really wants azithromycin to have additional anti-inflammatory type benefits. So yeah, I'll bookmark this and look at it.
Yeah.
I was excited because I pulled a paper from New England Journal that I think at least it seems like people are talking about. It was entitled Antibiotic Treatment for 7 versus 14 Days in Patients with Bloodstream Infections. So this newly published paper found that antibiotic treatment for 7 days for hospitalized patients with bloodstream infection was non-inferior to treatment for 14 days. So these were, to kind of summarize, uncomplicated non-staph aureus bloodstream infections. So some of the details. First, the acronym BALANCE trial, Bacteremia antibiotic link actually needed for clinical effectiveness. It's a little wordy, but I do like it. I'll give it like a 4 stars for clever and putting it in there. So this was a multi-center, open-label, randomized, controlled, non-inferiority trial comparing 7 versus 14 days in hospitalized bacteremic patients. It was conducted at 74 hospital sites in 7 countries in a window from 2014 to 2023, and they used 4 percentage points non-inferiority margin. So notable exclusions are severely immunocompromised patients, so those with neutropenia, who've had a transplant, Patients who potentially would need longer durations of treatment, so those with prosthetic heart valves, endovascular grafts, and a syndrome that clearly needs longer therapy like osteo or undrained abscess. And then they took out patients with cultures of common contaminants, and then Staph aureus and Staph lugdunensis fungemia, other rare organisms. And so the primary outcome was death from any cause at 90 days from the date of the positive index blood culture. And they had a long list of secondary outcomes. So death in hospital, death in the ICU admission, relapse bacteremia with the same bug, adverse events. I won't read kind of all of them, but they enrolled a little over 3,600 patients, 3,600. And the intention to treat groups included 1,814 patients in the 7-day group and 1,794 in the 14-day group. So the baseline characteristics between the two groups is pretty similar. The median age was about 70, about 53% were men. 55% or so were in the ICU at the time of enrollment. 3/4 or 75% had a listed sort of community source for their bacteremia. It most commonly was attributed to a urinary tract source. And then the top bug was E. coli at about 44%. The next two most common were Klebsiella and Enterococcus. Most of these were monomicrobial gram-negative infections, so that was about 70%. About 17% were monomicrobial gram-positive, and then about 10 to 11% were polymicrobial in both groups. So death by 90 days, that primary outcome, occurred in 261 patients, or 14.5%, in the 7-day group, and in 286 patients, or 16%, in the 14-day group. And so in the primary intention to treat analysis, 7 days was non-inferior to 14 days. And this was also seen in the modified intention to treat and per protocol analyses. And generally were consistent across the secondary outcomes. The drawbacks are that, like a lot of these other trials, the immunocompromised patients were excluded. There was a moderate amount of non-adherence to the duration, so 23% in the 7-day group and 10.7% in the 14-day group. So patients who received a slightly longer duration. But overall message is more for the shorter is better. We've had several smaller trials that have been published while this one was recruiting patients. But this one has a lot of advantages. It has a narrow non-inferiority margin. It's got a ton of patients, over 3,000, and most of those who were in the ICU, and then included a pretty wide variety of specific bugs. I'm not sure if they'll be able to do additional subgroup analyses looking at some of the individual bugs. They did look at it by sort of gram-negative, gram-positive, but I think, are there specific patients within these sort of categories that would benefit most sort of from these shorter durations? But I think very exciting, very cool. I'm sure it's going to be in most journal clubs that are coming up in the next few months.
All right. We have the article, The Long and Winding Road, 3-year mortality following prescription of multi-drug antibiotic treatment for Mycobacterium avium complex pulmonary disease, United States, Medicare beneficiaries with bronchiectasis, published in Open Forum Infectious Disease. Do you think that's like a Beatle reference? That song, The Long and Winding Road? I don't know.
I'm guessing. Hopefully we're not just making up references.
Yeah, no, I mean, I was over there in London recently, and I saw Albert Hall, and I was over by Abbey Road. So maybe I just have
Nice.
Beatles stuck in my head. So here they're basically asking a pretty simple question, do folks do better when we give them guideline-based therapy for MAC versus not? They look at 4,820 new MAC. They say PD users, pulmonary disease users. And, some of them are getting guideline-based therapy, and oddly enough, some people are just getting other stuff. And they actually see a big difference in mortality. The folks that get guideline-based therapy We look at 2 time points. So back in 2007, 15% versus those folks who don't, 22.1% died. And then they had a similar, about a 20% reduction in mortality when you follow the guideline-based therapy. So follow those guidelines.
And then I took a while with my last one. These last two that I have in the bacterial section are pretty short. The first one is from the Journal of Antimicrobial Chemotherapy, Efficacy and Tolerability of High-Dose Cephalexin, spelled with an F and not the American PH, 45 mg per kg per dose, maximum 1.5 grams, 3 times daily in children with bone and joint infections. This was a retrospective audit of 149 Australian children aged 1 to 18 years old who received 3 times a day cephalexin for hematogenous bone and joint infection. Majority of those children, 147 out of the 149, achieved cure, with those other 2 experiencing a recurrence. The take home is that most of the children did well. There were 4 kids who had some GI symptoms and 13 that had mild but uncomplicated neutropenia. So just looking at ways that we can use Keflex, like perhaps you don't have cefadroxil. I know that I feel like we sometimes reach for that. But mostly a reminder that 4 times a day medication dosing, like it is noted for Keflex, is terrible, and patients, and I think all of us should try to avoid that as much as we can. So, and then the last one I have is from CID, predicting risk of TB disease in people migrating to a low TB incidence country, development and validation of a multivariable dynamic risk prediction model using health administrative data. So these authors created and shared their process of this TB risk prediction model to help inform TB screening decisions in foreign-born permanent residents of Canada, using that, as they mentioned, health administrative data, which was pulled from British Columbia and Ontario. And so the link is https:// or you can just type in tb-migrate.com. And it uses age, sex, refugee status, country of birth, and some other factors like HIV and cancer, diabetes. I thought this was pretty cool and maybe something that people can hopefully think about and use alongside other TB prediction risk tools. So I have Periscope and the TST and 3D, whatever the hyperlink. I just have it bookmarked. But this one is a little bit unique because this score is focused on who to screen rather than looking at people who've had their TB screening already. So that's why, you don't see the IGRA or PPD in this TB Migrate tool, because it's kind of trying to achieve a slightly different goal there. So hopefully people can check it out. And I think this would be a really cool option if we had more and more of these as we were advising patients in clinic.
All right. Well, I will move us into the fungal section. Still waiting for The Last of Us Season 2. The article, Adaptation of Candida albicans to Specific Host Environments by Gain of Function Mutations in Transcription Factors, published in PLOS Pathogens. So this is a review, and I'm going to say very accessible. What are the takeaways? The yeast Candida albicans is usually a harmless member of the normal microbiota in healthy persons, but is also a major fungal pathogen that can colonize and infect almost every human tissue. Lots of discussion around how zinc cluster transcription factors are involved in the control of virtually all aspects of Candida albicans biology, and how mutations in these transcription factors alter their activity and the expression of their target genes, conferring a selective advantage. This results in the emergence of these phenotypically altered variants that are better adapted to new environmental challenges, including the ability to overcome antifungal therapy and to successfully establish itself in specific host niches. So I want to point out that this is nature doing gain of function experiments and should not be permitted.
Speaking of Candida, I pulled a review. Actually, New England Journal had several reviews over this past week or so that were really nice. So this one was on Candida auris infection, the budding yeast that we've talked about several times on the show, and now has spread to over 45 countries, 6 continents. Something interesting that I learned is that it thrives in high salt and high temperature conditions, and that this adaptability is thought to account for why it can persist in harsh environments, and actually has been postulated to be an environmental adaptation to climate change. And so allowing it to break through that human endothermy barrier, which is a factor in human resistance to infection by environmental fungi. So I'm not going to go through all of it. There's some great figures as usual. And then some of the other key points as take homes is that most strains are resistant to fluconazole. Some are resistant to all classes of antifungals. Echinocandins are the treatment of choice for patients with invasive Candida auris infection. And there's a higher treatment failure and relapse rate than with other Candida species. So I'm probably telling people who listen to this already know all these, but rather than going through all the details of the review, I'll just encourage people to check it out and give to their learners.
Now, it's always great to have a review like this, which sort of pulls everything together. So,
yeah.
All right, the article, Diagnostic Test Accuracy of the Fungitel Serum 1,3 Beta-D-glucan Assay for the Diagnosis of Pneumocystis jirovecii Pneumonia, a systematic review and meta-analysis published in CMI. You know what the best thing about Sarah, the beta-D-glucan test? It's talking about horseshoe crabs and their blue blood and the adipocytes, So I'm always a fan of talking about Fungitel, but how useful is Fungitel? So these are the results of a systematic review and meta-analysis to determine the diagnostic test accuracy of Fungitel for diagnosis of PCP, PJP, whatever you want to do that. Ultimately, 26 articles were including, looking at 5,111 patients, 1,150 PCP or PJP cases. At the conventional cutoff of 80 pg per ml, the sensitivity was 83.5%, specificity 75. We bump that up to 400. Sensitivity reduces to 23, but the specificity bumps to 93.6. So I don't know, maybe there's some role in there, Sarah, dare I mention? All right, let's move on. This one is great. This one just came up recently in an ICU patient. And it is the article, Do Patients with Candidemia Need an Ophthalmologic Examination, published in OFID. So for all those who wonder, they give us the background. Why have we been talking about this? Well, the ID, the Infectious Disease Society of America, recommends a screening dilated retinal examination by an ophthalmologist for all patients with candidemia. Conversely, the American Academy of Ophthalmology recommends against routine screening in patients with candidemia without symptoms. So when we follow our guidelines and ask them to look in those eyes, the eye doc follows their guidelines and reply with a collegial, no thank you. You can schedule that as an outpatient appointment if you would like. Well, here, in what they describe as a collaborative effort between infectious disease and ophthalmology, they examine the incidence of ocular complications in 308 patients with candidemia and subsequently measured the rate of fundoscopic examinations, risk factors for ocular complications, management, changes, and outcomes. Among those who received fundoscopic exams, findings suspicious for ocular candidiasis were found in 8%. After independent review by ophthalmology and infectious diseases, 3 patients were found to have alternative pathologies that explain their ocular findings. 6% were adjudicated as having presumed Candida chorioretinitis. Of these 9 patients, 4 were asymptomatic and 2 were unable to declare symptoms. No patients were definitively determined to have Candida endophthalmitis. Ocular candidiasis was not found to have a statistically significant association with symptoms or comorbidities. Ocular candidiasis was more likely to be found at ophthalmology exams greater than 7 days from first positive Candida blood culture. Now, the number needed to screen to detect presumed Candida chorioretinitis among asymptomatic patients was 20. So does this settle it, Sarah? Is it now settled?
I was just thinking, like, I wonder when the saga of when we're on the same page about who needs some will end. It feels like it's been a long time. It hasn't been that long.
But
But
we
I
now
think
have this
you were saying
wonderful.
like it came up in someone who was in the ICU. I mean, I think that's the challenge is those patients who are immunocompromised or in the ICU, and they're different than the patients who can tell you that they don't have symptoms. And I think that's where the sticky points get sometimes is that gray zone.
I think the tough thing, right, is so in this article, right, you start off with a number, but then as you kind of move on down, they're basically saying they didn't find like symptoms or comorbidities as having like a statistically significant association, right? Because they would say, if they're going to have it, they're going to give us some symptoms. Well, I don't know if this really is a big enough series to really answer that. So. All right, Parasitic. Be sure to listen to This Week in Parasitism, an update on guinea worm with the MMWR progress toward global dracunculiasis, guinea worm disease eradication, January 2023 through June 2024. This is a success story, right? So human cases of dracunculiasis, that's a hard one to pronounce, guinea worm disease, decreased from an estimated 3.5 million in 1986 to 13. Not 13 million, but just 13. 3.5 million to 13 in 2022. The circulation of dracunculiasis in dogs since 2012 has complicated eradication efforts. And here we read that 14 human cases and 886 animal infections were reported in 2023, and 3 human cases and 297 animal infections were reported through January to June of 2024. As of June 2024, dracunculiasis remains endemic in 5 countries: Angola, Chad, Ethiopia, Mali, and South Sudan. So far, so good, and program efforts have brought dracunculiasis close to the goal of eradication. However, dog infections and impeded access due to civil unrest and insecurity in Mali threaten the near-term possibility of global eradication. So Carter Wright just turned 100 October 1st. We're so close. Hang in there, Jimmy. The article, The Gut Micro... The reason I mention that is he's, really was a big leader of the Carter Center in the guinea worm disease eradication efforts. All right, the article... The gut microbiota is essential for Trichinella spiralis, evokes suppression of colitis, published in PLOS NTDs. This might be a good deep dive on TWIP at some point, but our listeners might be familiar with the fact that clinical and experimental evidence has demonstrated protective effects of parasitic helminth infection against inflammatory bowel disease. We know that infection with helminths induces alteration in the host microbiota composition. So here they analyze the intersection of helminth, Trichinella spiralis, and gut bacteria in the regulation of colitis and related mechanisms. Sort of interesting, right? You don't really think of Trichinella in the gut. You're thinking Trichinella in muscles. Well, T. spiralis infected mice were treated with antibiotics or co-housed with wild-type mice and then challenged with this colitis model, this dextran sodium sulfate colitis. They're going to look at disease severity, immune responses, goblet cells. They found that protection against disease by infection with T. spiralis was abrogated by antibiotic treatment, and co-housing with T. spiralis infected mice suppressed the colitis in wild-type mice. Bacterial community profiling revealed an increase in the abundance of the bacterial genus Muribaculum and unclassified Muribaculaceae in mice with T. spiralis infection or mice co-housed with T. spiralis infected mice. Metabolomic analysis demonstrated significant increased propionic acid in feces from T. spiralis infected mice. Data also showed that the gut microbiome modulated by T. spiralis exhibited enhanced goblet cell differentiation and elevated IL-10 levels in mice. So really adding a lot of complexity. It was sort of this goal that we're going to figure out, what what single cytokine or single protein is being secreted by the helminths, and that's going to be our miracle cure for inflammatory bowel disease. It looks like there may be some kind of an interesting interplay with the gut microbiome. All right, and I think we've got a couple more here to go. One by me, and then Sarah's going to finish us off. But the article, Symptomatic Entamoeba dispar infections among men who have sex with men in New York City, 2018, was published in OFID. Now, this is another one of the, maybe the things they taught us were not true. I love these. Well, you should, like, loving when you find out that you're wrong, so that you've now learned. That's what learning is. Okay. It's not just learning that you're right. A cluster of cases of amoebiasis with reported diarrhea were identified in a neighborhood in Manhattan, New York. In 2018, all the patients had Entamoeba cysts and trophozoites. By PCR, these were all E. dispar, not E. histolytica. Now, 83% were positive for Blastocystis hominis. 1 was positive for Shigella, Giardia, and Entamoeba coli. Mostly MSM with reported sexual content. So potentially a paradigm shift if it turns out that E. entamoeba is not just E. entamoeba, but E. histolytica is pathogenic, and it isn't all just E. histolytica.
Yeah. And I had also pulled this one, I think Daniel had too, the article Angiostrongylus cantonensis, meningoencephalitis in 3 pediatric patients in Florida, was published in JPIDS. So eosinophilic meningoencephalitis caused by Angiostrongylus, aka the rat lungworm, has been reported in several southern U.S. states, and I'm sure for people who've been studying for boards, also remember Hawaii. The authors here present the first locally acquired human cases of Angiostrongylus meningoencephalitis in 3 children in Florida. These occurred between June 2021 and January 2022. So they had a case in a 19-month-old, a 10-year-old, and an 8-month-old that they gave you a little description of in the article. The definitive diagnosis requires visualizing the larvae in the CSF or detection through PCR of CSF samples. There is no serological testing. I did learn, so the Angiostrongylus cantonensis PCR diagnostic testing is only available through Hawaii State Public Health Labs for patients in Hawaii, and then the CDC Parasitic Diseases Labs. I think what was interesting about this is that these patients, the organism was picked up on a Carius or microbial cell-free DNA next-gen sequencing. I'm sure because, we not infrequently reach for that type of test. So I just thought I'd point that out because it seems like that probably gave them a more a sooner link to what the causative bug was.
Yeah, I mean, that's one of the great things about Carius, right? I mean, they probably weren't thinking, because the idea was, hey, this is an endemic; it's not in the differential.
Yeah.
Yeah. So we've got Angiostrongylus, so we've got rat lungworm in the U.S. We've got dengue has become endemic. Just
I think the undetermined CNS infection that you can't understand is one of the places where, at least in my mind, I lump that as like a box where cell-free DNA is probably a pretty useful resource, and trying to do it on the earlier side can really help you get to diagnosis in some cases.
Yeah, I mean, it's a admitting humility type thing. It's syndrome-based diagnostics instead of saying, I'm going to figure this out. All right, miscellaneous. We've got a bunch here. The article, Snake Phobia Among the General Population of Tamil Nadu, India, published in PLOS NTDs. So I'm going to say, Sarah, I take issue with the term phobia. Like, what is a phobia, right? So I looked this up. Because, right, so according to the Merriam-Webster dictionary, phobia is an exaggerated, usually inexplicable and illogical fear of a particular object, class of objects, or situation. Now, we read that to date, only one standardized psychometric test, the Snake Questionnaire, SNAC, developed in 1974, has been used to quantify snake phobia, although this was not performed in snake endemic countries. In this study, we're gonna look at snake phobia in India. So they're going to look at over 2,000 responses, and they're going to tell us that males are more snake phobic in all age groups than females in India, in contrast to previous research that suggested it were the ladies that were more snake phobic. And the reason I take issue is that it is appropriate to be terrified of snakes.
Yeah, I was going to say the same thing.
Come
It seems
on.
appropriate to be scared of something that can cause you harm.
Yeah, so I spent some time in Tamil Nadu in Vellore, right? And I always make sure I time my trips. I want to go during the rainy season, right? When there's so much rain and flooding that all the people and the snakes are all concentrated in these little areas, right? So I can see a lot of like cool snake stuff. And they've taught the people, right? You get bit by a snake, you grab that snake and you bring it in so that, help us with the anti-venom decision. And so in the ER there, they've got all these like snakes like nailed up on the wall, right? And they've got like identification. And then you ask like, hey, hold up your snakes. And everyone holds up their, it's horrible. It is appropriate. It is not illogical or inexplicable to be deathly afraid of the serpents. Okay.
Oh, not quite as exciting as that. I pulled a paper from OFID, Remote Practice of Infectious Diseases Through Telemedicine, Improving Access for Patients and Appeal for Physicians. So this article is proposing, it's a perspective, proposing that ID telemedicine is a solution and alternative model to help reduce physician burnout. So the authors share their tele-ID practice, which includes caring for inpatients and outpatients through live audio-video visits. So sounds like a local on-site nurse that can help with the physical exam and using the remote stethoscope and things like that, as well as e-consults. And they give the perspective of two physicians who previously practiced, quote, in-person ID and now have transitioned to tele-ID. I thought it was actually probably most useful to hear about some of the drawbacks, like physician isolation and perhaps feeling like you have less accessibility to colleagues, and perhaps reluctance on the part of both patients and other colleagues to interact with telemedicine clinicians that are 100% remote. It sounds like their group has tried to combat this with attendance at academic conferences and seminars and things like that. There aren't a lot of details. There are obviously a lot of big needs and, operational pieces that aren't here about how to actually do virtual care models. It's more of sort of describing maybe this would be a fit for certain individual clinicians who feel like it would give them a better, balance / integration to their life. So I thought it was interesting. I don't know that it, brings new information. It just gives you a little bit of insight into folks who've made that transition and how they've enjoyed working in that setting.
Yeah, I'm a little worried, Sarah, about the near future of telemedicine, right? So prior to the pandemic, if you wanted to do telemedicine, there were all kinds of rules. Like the person on the other end had to be in a geographically disadvantaged, underserved area. They had to go to a special telemedicine site. And then during the pandemic, we just did a tremendous amount of these telemedicine visits where the patient was in the comfort of their own home, maybe following them after a recent COVID diagnosis, right? That was a big one. Make sure they didn't get readmitted. Started using it a lot of times to follow people with their outpatient IV antibiotics, make sure the PIC and the midline is fine. And it's really been tremendous. But unless there's legislative action taken, all these new exemptions are going to go away January 1st. Really could be a disadvantage as far as access. And I think we've talked about before, 80% of counties in the United States have no access to an ID doc. And so this has really been tremendous. I'm hoping that we continue to see an expansion of telemedicine. I'm hoping the legislation is addressed it's only about a month ago here. But yeah, I think that's really interesting. The drawbacks, yeah, it can be isolating, right? You're in your office, you're not having that physical interaction, you're not necessarily bumping into your colleagues in the halls of the hospital. So, all right. Gauging medical students' interest in infectious disease was published in CID. The investigators developed a 26-question survey to gauge interest in infectious disease. 16 medical students in Texas were contacted, invited to participate. All 16 medical schools, not just students. Total of 262 students, it'd be a small n, across 9 medical school campuses completed the survey. Those interested in ID as a career had a significantly higher interest in public health and global health. Those really stood out. The presence of an ID campus interest group and direct experience with the ID profession were also associated with interest. The most common reasons for lack of interest were not wanting to pursue internal medicine or the pediatric residency, lack of compensation, lack of procedures, and those interested in ID expressed interest in a wide variety of career pathways within ID, the most common being general inpatient and outpatient ID, as well as medical microbiology and global health, tropical medicine, and travel medicine.
That's interesting. Lack of interest in doing the initial residency.
Yeah, it is a little strange. Like, kind of maybe if there was like direct
question.
track, like if we had like a 4 or 5 year direct track ID, like I just want to. But I think they might miss the fact that like we are the consummate general internist, right? We're called all the time, and you're like, no, I actually think what this is a non-infectious etiology. It's just as often as not. So.
Yeah. Well, I thought this was going to be a nice one to end the episode on. This was from OFID, Shaping the Future of Infectious Diseases, the Journey to Promote Value, Opportunity, and Positive Messaging. This summarized discussions from the ID Week National Fellowship Training Program Directors Meeting about the future of ID, strategies to highlight for the future. It's a relatively quick read. They broke it down into sort of value, opportunity, and positive messaging. And if you look closely in Table 1, they have a nice summary of areas where the value of ID is measurable and notable. They also have a table talking a little bit about engagement opportunities. So bringing in, for example, those earlier learners who might be interested in ID and getting them plugged in and hopefully creating some of those relationships or mentorship opportunities. And then I hope that I and others and have really been ambassadors for positive messaging instead of the doom and gloom of ID, that we should celebrate and promote those that are in our ID specialty, because I think at its heart, like, we feel that way. Sometimes if you're tired, you may not communicate it that way, but being intentional about positive messaging. So with that brings us to the end of this podcast. As always, the references for the show are available at microbe.tv, the home of our growing multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast, or grab it with your favorite podcatcher. We love to get your questions, comments, and paper suggestions. Send them to puscast@microbe.tv. If you like what we do or you just want us to keep doing it, consider supporting the science shows of Microbe TV at microbe.tv/contribute, or during our January, February fundraiser, go to parasiteswithoutborders.com, and we're going to double up to a total potential of $20,000 to support Microbe TV.
Love it.
That's a lot of money for an ID doc, Sarah.
I'm Sarah Dong. You can find me at Sarah Win Dong or at Febrile Podcast. I've migrated over and made my Blue Sky accounts. People can find me there, or at febrilepodcast.com.
I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center at parasiteswithoutborders.com. I'm also on Blue Sky, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.